Good evening, everyone. Welcome to today's class. We're going to be online for about an hour, and we're going to continue from where we stopped yesterday. I'm going to need you to mute yourselves. I'm just going to mute everyone from my end. Okay, so now I have the floor, and I think we can proceed. Okay, so let me sort. I'm not sure where we stopped yesterday. Clients atrial despite pharmacological. Okay, so I think we reviewed this yesterday. I'm not sure where we stopped. Did we do this yesterday? Okay, I think if I'm not mistaken, this is where we stopped yesterday. And I just pray we can run through all of what we need to cover. Let me just check. So that's yesterday we were only able to do like 5 slides, which was very, even though it took us over an hour, 30 minutes. Hopefully we'll do more today. So it's 2, 3, 4, 5, 6, 7, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28. Okay, so we just have 28 slides. Let's see if we can run through all of it. Let me see. Okay. So please, okay, let me just set this to mute all on entrance. Okay. So again, we have the same question on our screen. It says the telemetry nurse reports the cardiac monitor readings of 4 clients to the medical unit nurse assigned to care for them. The nurse should assess the client with which reading first. Again, this is a who do you see first kind of question. On our course, we would have taught you all of those techniques you need to use to prioritize. Again, it's not like you must know all of your topic. It's about using those techniques to prioritize and know which I want to go with or which technique I want to use to eliminate the wrong answer choices. Yes, you still need to know your content, but again, if you use all of those techniques, it makes it a whole lot. So it will make it a whole lot easier. So do we need to see the client with atrial fibrillation with a pulse of 76 beats per minute in a client prescribed rivaroxaban? Again, what's that medication there? Again, when I think of clients with atrial fibrillation, and again, that's how I want you to look up with all of the contents you read. When I have a medical condition, I want to think of what is the worst thing that can happen with this particular patient. Again, ask yourself, what is happening in clients with atrial fibrillation? Okay, so let me get my marker there. Okay, so again, this is our patient's heart. These are the upper chambers, these are the lower chambers. Again, the atrias are fibrillating. They are not pumping blood as they should. They are kind of stagnating the blood. Okay, so thank you, confidence. It says rivaroxaban is a low molecular anticoagulant. Again, don't let confidence scare you. Just know it's an anticoagulant. So you don't feel like, I didn't even know it's a low molecular one. But again, it's an anticoagulant. And why do they need to place clients? Would it be expected that clients with atrial fibrillation would be placed on anticoagulants? Yes, because when the atrias are fibrillating, the blood starts to stagnate within the atrias. The blood starts to sit within the atrias and kind of remain there. And the more they stagnate, the more this client is at risk of throwing a clot. Again, if you don't know anything about nursing and you're going for the Nclex, at least you should know that atrial fibrillation, these guys are high priority for throwing blood clots. Again, these blood clots can shoot out, some can go to the brain, cause a stroke, it can go to the heart, cause a coronary event. It can go to the lung veins and cause a DVT and all of that. So you always want to be mindful. Whenever I see atrial fibrillation on the Nclex, I'm already thinking about these guys can throw a blood clot. And would it be normal? Would it be expected to have this client based on rivaroxaban? Yes, it's expected. So that would not be the patient I want to see first. So again, I can eliminate option 1. How about the client with bradycardia? Again, what is bradycardia? Most textbooks will say a heartbeat less than 50. Some will say a heartbeat less than 60. But again, we know that in bradycardia, the heart rate is slow. It's affecting cardiac output. But why did the Nclex go forward to tell me the client has a demand pacemaker set at 70? You want to start thinking, why? Why did they have to mention this? Because if I think about it, we talked about pacemakers yesterday, and we said pacemakers, we need to pace the heart and all of that. And we'll talk about it on the main core content course. You can have a demand pacemaker. You can have a fixed pacemaker. So again, I won't go right into it now. But again, for a demand pacemaker, usually what happens is that when we insert these pacemakers, we set a rate that we want it to beat to drive the heart. So it's almost like telling the pacemaker that if this heart rate goes, if this heart rate goes below 70, I want you to take over and start pacing this heart. So if this client has a demand pacemaker already set at 70, and yet he's bradycardic, I should be concerned. I should be worried. There's a reason this client is actually unstable, because his pacemaker doesn't seem to be functioning as it should. So again, that's it there. There's a reason they gave us this information, that this client is on a demand pacemaker, and yet he's bradycardic. So I would be concerned about the client in option 2. How about number 3? A client with a first-degree AV block. A first-degree AV block in a client prescribed atenolol. Again, would I have any reason to be concerned that this client who has a heart block, a first-degree AV block, is prescribed atenolol? Again, that's what you should be thinking. Would this cause me concern? Sorry, just 1 minute, please. Okay, sorry about that. So again, we are looking at option 3. We said the client with AV block who has been prescribed atenolol. Again, this would be expected with beta blockers. Remember your OLOL. So those are your beta blockers. Maybe we'll review some of these medications when we look at our medications we need to know for the Nclex. Again, we know that these kind of medications will delay AV node conduction. So again, this would be expected in this client. How about the client with a sinus tachycardia? He's in a sinus tachycardia, but he has gastroenteritis and dehydration. Again, what's a sinus tachycardia? Tachycardia means the heart rate is fast. But which type of tachycardia is this? Remember, we talked about ventricular tachycardia, we talked about supraventricular tachycardia and all of that. But with a sinus tachycardia, so normally, what this tells us, that it tells us that the impulse that is causing this heart rate to be fast, it's actually following the normal conduction pathway of the heart. It's coming from the SA node. That is why it is called a sinus tachycardia. Again, what could cause your client to have sinus tachycardia? If you are anxious or anxiety can cause your heartbeat to be fast. Dehydration can cause your heartbeat to be fast. So again, we know that this client has gastroenteritis. Infection can also cause the heart rate to be fast. So again, I'm going to ask myself, would tachycardia be expected in a client with dehydration? Obviously, yes. So again, I can also eliminate option 4. So we are left with option 2, which is our correct answer. Let's look at another question. A client remains in diagnosed atrial fibrillation. So again, we already talked about atrial fibrillation, and just to remind ourselves, we said your core concern with atrial fibrillation would be that they are at high risk of throwing blood clots. So again, here we have another client with atrial fibrillation with rapid ventricular response despite prescribed pharmacological intervention. So again, synchronized cardioversion is scheduled to convert the rapid rhythm. Which action should the nurse plan to take to ensure safety and prevent complications of this procedure? Yesterday, we talked about synchronized cardioversion, and we attempted to differentiate it from defibrillation, because both of them, like we said yesterday, are electrical therapies. These are electrical therapies you can use to treat your patients. So again, they're asking us what action the nurse should plan to take to ensure safety and prevent complication. So again, with synchronized cardioversion, one of our highest concern would be most times people would just charge the machine and shock. They would forget to press the sync button. I talked about this yesterday, and I said, you want to go back to your defibrillator and look for the sync button. Because if you do not press the sync button and you go ahead to charge the machine and you shock the patient, you have not cardioverted that patient. You have actually defibrillated that patient. So number 4 is going to be my correct option. Again, remember, the Nclex is a safety examination. They know you are even though you have been practicing for donkey years in Nigeria, but because they just recently enrolled you, you are being categorized as an entry-level nurse. And they don't expect you to be 100% proficient and competent on the job. So they just want to be sure that on your first day on the job, you're not going to kill someone. On your first day on the job, you're not going to make a critical mistake that can kill your patient. And that's why it's always about safety on the Nclex. I'll always go with, if I don't know an option to a question, I would always go with the most safety conscious option. And again, like I said, you always want to follow your nursing process. It's always going to be there to guide you. Because if I look at this option, all I need to do is say, if I need to do this, this is my only assessment option here. And that again makes number 4 the correct answer. You always want to use all of these techniques when you are reviewing questions on the Nclex, especially for the ones you don't know. Try out all of these techniques that will teach you on the course, and it will help you to select and eliminate wrong answer choices and improve your chances of getting the correct option. So again, number 4 would be our correct answer. Yes, you might say this cardioversion may be a painful procedure, but if our client is unstable, like you can see here in the question, is having rapid ventricular response. If it's unstable, then it's an emergency. You don't want to delay cardioversion for sedation. You don't want to delay sedation, cardioversion because of sedation. No. If your client is unstable, go ahead and cardiovert without sedation. Okay, so let's look at another question. So hopefully, I don't want to spend more than 1 minute on each slide, so that at least if we stay 1 hour, we should at least complete 60 slides minimum. Okay, now we have this rhythm strip in front of us. It's given to the nurse by the telemetry technician. The nurse recognizes it at which rhythm? Again, would this be atrial fibrillation? Yesterday, we talked about atrial fibrillation, and we said that the atrias are fibrillating. Again, you are going to see those fibrillatory waves. We'll see those fibrillatory waves, and then you see a narrow QRS complex. And then we see those fibrillatory waves again, and then we see those narrow QRS complex. That's your atrial fibrillation. So this is not an atrial fibrillation. Again, is it number 2, your first degree AV block? Again, when I see AV blocks, I remember that AV blocks are bradycardic rhythm. These are bradycardic rhythm. Look at this slide. Would you say this is a fast rhythm or a slow rhythm? There are many ways to determine the rate of an ECG strip. Even just by merely looking at it, I can see that these are evenly spaced apart and they're not too far apart from each other. So it kind of looks normal to me. Another way you can do this is to check the rate. And please, when you are reading, try to stick to one technique. If, for example, you have mastered the art of using our 300, 150, 100, 75, 60, 50. If that is the technique you want to use to determine your rate, then stick with it. There's no need mastering all of the different techniques. And then when you come on the Nclex, you are anxious, you are not sure which is the right one again. And now you are doing, okay, well, 1, 2, 3, 4 big blocks divided by 1,500. Or is it the tiny boxes divided by 300? Then you confuse yourself. So for me, the easiest way I would recommend is using the 300, 150, 100, 75, 60, 50 rule. Because all you need to do is to pick out a QRS complex that falls on a thick line, and then you want to write out these numbers. Again, don't bother about where am I getting the numbers from. Just memorize it. 300, 150, 100, 75, 60, 50. 300, 150, 100, 75, 60, 50. That's all you need to do. Because I know this line is 300, this line is 150, this line is 100, this line is 75, this line is 60, this line is 50. So all I need to identify is where did the second QRS fall? Where did the second QRS fall? And again, from my numbering, I know that it fell, sorry. So from my numbering, I know it fell between, okay. So it is my 351, 300, 150, 100, 75. So this is 100. So this is 100 and this is 75. So this QRS complex fell between 75 and 100. And that's within the normal ranges for a normal rate. So again, this cannot be an AV block. An AV block would be a much slower rate. Again, would you say it's a sinus bradycardia? I would not. Even though, yes, it's of a sinus origin, meaning I can see my P waves. Those P waves tells me the atrias are contracting. Those P waves tells me the SA node have fired. Even though this is of a sinus origin, but it's not a bradycardic rhythm because the heart rate is between 75 and 100. So number 3 is also wrong. Could this be a sinus rhythm? Obviously, I see P waves. For every P waves, I see a QRS complex. For every P wave, there's a QRS complex. For every P wave, there's a QRS complex. That's one feature of a normal sinus rhythm. Another feature of a normal sinus rhythm would be to look at the intervals between them. Look at our RR interval. Does this look the same? Because if the same, then it tells me it's a regular rhythm. That is another feature. Another thing I want to use and identify a normal sinus rhythm would be to look at the QRS complexes. So again, if I look at them like someone's leg. So if the two legs are close together, I say, yes, this is what is expected. But if the two legs are wide apart, then that tells me it's of a ventricular origin. If you look at this rhythm, the QRS complex, the legs are narrow. That's another feature of a normal sinus rhythm. Which other feature can I remember now? So I think those are the 4 major ones. So the rate is within the normal rate of 75 to 100 or 60 to 100. The rhythm is regular. So we've measured the RR interval and it tells us it's regular. We have a P wave and there's a P wave present before every QRS complex. So we have that kind of 1-to-1 ratio, meaning for every P wave, there's a QRS complex. Well, I won't want to go into the PR interval now, but again, the PR interval looks normal to me. Remember, I want it to be less than 5 small boxes. We'll talk about it on the core content course. But again, sorry. So if you look at the PR interval, but I didn't want to go into it. But again, if you look at the PR interval, we want it to be less than 5 small boxes. So that's my PR interval there. Sorry, my pen is messing up. Okay, so from the beginning of the P wave to the beginning of the QRS complex is our PR interval, and we want it to be less than 5 small boxes. Again, this is within range. This is less than 5 small boxes. Again, look at the QRS complexes. Their legs are touching together. That's in layman terms, but again, if we want to talk about them in the right terminologies, we want our QRS complex to be less than 0.12 seconds. We'll talk about this in the core content, but again, just by merely looking at the legs, are they almost touching? Are they close together? If it's close together, we say it's narrow. If they are wide apart, we say it is wide. So number 4 would be my correct option because this is a normal sinus rhythm. Okay, an unresponsive client is admitted to an emergency room. The client's cardiac rhythm is extremely irregular with no measurable heart rate, no P waves, no QRS complexes. The nurse leading the resuscitation team should direct the team to perform which action first. So again, we talked about CPR yesterday, or resuscitation. We talked about resuscitation yesterday, and we said if your patient presents in a cardiac arrest, so let me see if I can pull this up just to make it more realistic. So just give it a minute. Okay. So let me look at my panel, reading keypad. Okay, let me see. Where do I have my VF? Okay. So if your patient presents in ventricular fibrillation, such as we have on our screen, 1 minute. So that would be ventricular fibrillation. Again, you can see the rhythm looks chaotic. There's no discernible P wave. There's no discernible QRS complex. That's all you see on your patient monitor. Again, once you see this on the Nclex, there's no big grammar. Shock the hell out of the patient. Again, we said yesterday, if the patient is in VFib, you want to defib. And what do I need to do when I see this rhythm? I'm going to come to my monitor, and you can see where I have charge. So I'm going to come and I'm going to charge the machine. And once it's fully charged, the light is going to come on. I'm going to press the shock button. Again, remember yesterday we said, once you shock the patient, the next thing you want to do is to resume chest compression. So I'm going to charge the machine here and watch as the light fully comes on. Okay, so I need to press the flashing button now. Again, when I press the flashing button, I need to look out and make sure if there is a return of spontaneous circulation. I'm going to check the pulse and see if I've really defibrillated this patient. So that's how you want to carry out defibrillation. So again, if you see ventricular fibrillation on the Nclex, so this is your ventricular fibrillation again. We said there are two shockable rhythms. One of them would be your ventricular fibrillation, and the second one would be your, okay, so let me try and put it up here. So this would be second shockable rhythm, which would refer to as a pulseless ventricular tachycardia. So it has a pulse. Again, this is a ventricular tachycardia actually, but if the patient presents with this and he doesn't have a pulse, so please just ignore the pulse that's showing here. Just focus on the rhythm. If the patient presents with a ventricular tachycardia and he did not have a pulse, this is automatically a pulseless ventricular tachycardia, and it's a shockable rhythm. So they're going to tell you on the Nclex, this patient came in with this rhythm, and the nurse assessed him, and the nurse noticed that there was no carotid pulse. What should the nurse do first? Shock the hell out of this patient. So you're going to go back to your charge. We're going to charge the machine, and we're going to shock the patient. And what next do? We resume CPR. So that's what you're going to do when you have a patient who presents with any of these scenarios. Okay, so let's go back to our question slide. I hope it made a whole lot of sense. Where do I need to minimize this? Sorry, 1 minute. Okay. Again, number one is going to be our correct option. Again, number two will not be your correct option, because if the client has no P wave, no discernible QRS complex, is in cardiac arrest. If you have your AED or your manual defibrillator, you want to use it, shock the patient as soon as possible. And we would not administer epinephrine. We would not administer epinephrine until after the second shock. Please write this down. It might come handy on your test day. We do not administer epinephrine until after the second shock. Again, after the second shock, after the third shock, we might use amiodarone or lidocaine. We talked about this yesterday. Again, number three will not be the correct answer, because you don't want to perform synchronized cardioversion. We only want to do synchronized cardioversion for an unstable tachycardia. And we would not prepare for pacemaker insertion, because we said we were going to use pacemaker for heart rhythms that are slow those especially for like second degree type 2 and your third degree heart blocks. That's where we want to use our pacemaker function. Okay, let's look at another slide. A client with a permanent pacemaker, so he has a permanent pacemaker with continuous telemetry, calls the nurse and reports feeling lightheaded and dizzy. I'm already thinking unstable clients, unstable clients, unstable clients. That's why they are telling you those. They are again, always ask yourself, why didn't they just say client with permanent pacemaker, blah, blah. Why did they have to tell you he's lightheaded and dizzy? Why did they have to give us this hypotensive reading? What would be your priority action? So that's what they're asking me. What would be my priority action for a priority action for an unstable patient? I've not even looked at the reading yet, but again, I'm already hitting number 4 because in real life setting, you're not going to just see a patient who calls you and says he's feeling dizzy, and the first thing that comes to your mind is, call Dr. Onyeka, call Dr. Onyeka. No, you are a trained professional. Ask yourself, is there something I can do before I call Dr. Onyeka? Is there something I can do? And even if I call Dr. Onyeka, what am I even going to tell him? You must carry out your initial assessment. At least let's even have, yes, the patient has told you, but he has told you he's feeling dizzy, he's lightheaded, the client's blood pressure is 75 over 55. But is there something you as a nurse can do before you call doctor? There's a reason they gave us all of this information. Look at the ECG strip. Yesterday we talked about pacing. And I didn't want to spend more than 1 minute on each slide, but my laptop. Okay, so let me call up my simulator so that it just to make it a whole lot clearer with the pacing, because most people might not be familiar with this pacemaker function we've been referring to throughout the course. Okay, so I'm going to pick a rhythm. Sorry, 1 minute. Just have to increase this. So, sorry, the stuff is hiding. I just need to figure it out. Okay, so let me just do this. What is this thing? Okay, I'll just have to use this. The one I was trying to use it's not coming up. So let me hope this works perfectly. But the one I wanted to use is not coming up as it should. Okay, so back to our monitor again. So let me just widen this. Okay, so again, this patient looks to me like someone with a slow rhythm. And if this isn't going to work. Okay, so let me try this. Okay, so we see a patient with a slow rhythm. And then we need to pace this patient. So I'm going to go to my pacer button. So that's my pacer button there. So I'm going to go to my pacer button and I'm going to click the pacer. So there's some, I need you to look at the rhythm strip now, and then look at it when I click the pacer mode. Well, this isn't working as I wanted to. It's not allowing me to display. It's not displaying the buttons here. Okay, I'll just suspend this. Maybe I'll sort it before the live class, but it's not allowing me. So I just wanted to show you what's happening here. So with pacer, when you are pacing, you're kind of trying to increase the heart rate using your defibrillator, your monitor. And again, when you are pacing, you always want to look out for what we refer to as our pacer spikes. So these are those pacer spikes we talked about yesterday. So these are your pacer spike. Again, for you to know that you are pacing this heart, there must be electrical capture, there must be mechanical capture, there must be physiological capture. You are looking out for three of this. If you've taken over pacemaking or the pacer mode or pacer function of the heart, for every time you see a pacer spike, it must be followed by a change in the QRS complex. For every time, that's what it should be. That's what will tell you you are effectively pacing this patient. For every time you see a pacer spike, it should be followed by a wide QRS complex. But now we see a pacer spike here, and there's nothing happening here. We see another pacer spike here, and here there's nothing happening here. And then you have a pacer spike. Sorry, you have a pacer spike here. Then we see some difference. Again, we are back to this again. There's a pacer spike, and then nothing happening after it. There's a pacer spike, and nothing happening after it. That tells you your machine is actually working as it should, but it's failure to capture. And that failure to capture is what is causing bradycardia and hypotension in this client. That's why he's complaining of all of these symptoms. He has a pacemaker because they've told us he has a permanent pacemaker. And yet, we are seeing this on the rhythm. It means this pacemaker is not functioning as it should. Your priority would be to stabilize or normalize this patient's heart rate. You want to stabilize the blood pressure, because if the blood pressure, if the cardiac output is diminished, it's going to affect the perfusion of the vital organs. So again, what do we need to do to stabilize this patient? We need to initiate transcutaneous pacing. Remember, the permanent pacemaker is the one that is inserted into the body. But if that one has now failed, as we can see on the ECG strip, then it means we need to initiate transcutaneous pacing. Trans means through, cutaneous means skin. So we're going to have to do this through the skin, at least to stabilize him, normalize the heart rate, while we get to, or maybe get the technique, get the doctor involved to know why the permanent pacemaker has failed. So again, like I mentioned, before you jump on the rushing to call the doctor, ask yourself, is there something I can do before I call the doctor? So I need to gather more information before I call the doctor. Your dopamine and atropine number one and number two. Well, dopamine, is used to treat hypertension due to bradycardia. Again, the ECG strip is telling us otherwise. The ECG strip is telling us he has a permanent. Well, this would be a ventricular pacemaker, yes, because you're going to see it. We are seeing it just right before the QRS complexes. So confidence, yes, it is a ventricular pacemaker. Okay, honestly, the time has again run by. It's just 8 p.m. But again, let's try and run through maybe another one or two slides, and then we can call it a day. I've had a very, very busy day. So the client is admitted to the cardiac unit and placed on telemetry. The nurse reviews the client's lab results and knows that the potassium level is 6.3. Again, what's our normal? Remember, I talked about the 3 fingers of banana and the 5 fingers of banana. So again, my normal should be between 3.5 to 5. So again, my client is in hyperkalemia. And these are some vital statistics, or like what I don't know what I'll call it, some lab values you need to know, or some indicators, your ECG indicators. Because if I see that my client is hyperkalemia, what do I need to see on the Nclex? What would that show? What will I see? Or how does hyperkalemia show on the Nclex? You're going to see a tall peaked T wave. That's one thing you will see if your client is in hyperkalemia. You're going to see a tall peaked T wave. So please memorize this. Don't go into the details of why is it peaked, or just know that entry level nurse, that's what we need you to know. That if you look at your ECG strip and you see, so this is your P wave, your QRS, so this is your P wave, your QRS complex, and instead of seeing your rounded T wave, instead, what are you seeing? Almost like you're going to have two QRS complex. You're going to have like two QRS complexes because your T waves become tall and peaked. So again, that tells me hyperkalemia. If you don't take anything out of today's class, just remember that if I see tall peaked wave on my ECG, that tells me hyperkalemia. How about if the client is in hypokalemia? What would you see on the Nclex? Most times, from nowhere, you see this U wave. A U wave appears. Normally, you don't see this. Most times, we see it in pathology. But again, if I see a U wave, and I look at our ST segment, remember we talked about our ST segment yesterday, and we said it's supposed to be flat. So that's my ST segment there. But if you see it peaked, if you see it elevated, we said it tells you your client is having a STEMI. Again, it can also face the other way around. So your ST segment can also be what? Depressed. So you can see a depressed ST segment. So if I say a U wave in combination with a depressed ST segment, that tells me my client is in hypokalemia. So number 3 is almost tilting towards hypokalemia in your clients. And one other one you need to know, very, very important, when you see prolonged QT interval on the Nclex, start thinking about low levels of not potassium, low levels of calcium. So if I see prolonged QT intervals, that tells me my client may be hypocalcemic. Again, what's our normal level for calcium? Calcium, C-A-L, calcium, that's like call. What do I call? Call 911. Again, that helps me to remember that my potassium levels should be between, some will say 8.5 to 10.5. But again, when I see calcium, call 911. So I know that from 9, I just go back a bit, and from 11, I go down a bit. So my calcium will be 8.5 to 10.5. And please, don't get confused with my own lab values. It depends on which material you are using. If that's why I tell people, I have a lady who I visited, a colleague. I visited her room. She had a full textbook photocopy of Saunders. And then she also has another textbook photocopy of UWorld. And she has another textbook photocopy of Lippincott, all Nclex. And I'm like, are you supposed to read all of this? So don't, because you see that Chidinma is reading Lippincott, you do photocopy. Amaka is reading Saunders, you go and photocopy the textbook. In the end, you confuse yourself because some of these textbooks will give you different lab values. But again, the Nclex has taken that into consideration. So if they're going to give you a wrong lab value, they are going to consider that Lippincott says 9 is correct. Saunders say 8 is correct. This other one says 7 is correct. So they will go back away from all of these numbers. So whichever textbook you read, you don't fall into the, it's still correct for each of these textbooks. So don't keep jumping from one material to the other. You pay for UWorld, you don't pass the Nclex, you come back, you pay for Archers, Archer will even tell you you've not even done anything, you are not ready. You feel depressed, you feel demoralized, you feel you've not done anything. Stick to one material. Know your content, stop jumping up and down. So again, if my lab values are not correlating with your own lab values, it's not a problem. We probably are using different materials, and we are all correct if you can quote what you read from your own material. Okay, and then the last question we'll take would be this. The client is admitted with palpitation, a heart rate of 220 per minute. Again, that tells me this client is tachycardic. The nurse has received an order to administer adenosine 6 milligram IV. Which action should the nurse take? Again, even though I keep modeling everything up, but I'm just giving you all those nuggets you need to know. Whenever I see adenosine on the Nclex, 6 milligram, always remember, if you need to repeat adenosine on the Nclex, you need to increase it 12 milligram. So write it down. Adenosine, first dose, 6 milligram. Second dose, 12 milligram. You want to remember that on the Nclex. Again, how do I mean repeat? So we have this client in tachycardia. We've given adenosine. We are going to watch and see if there's any change. And after a while, he's still tachycardic. If we need to repeat the adenosine, please double the dose. Another thing you need to know about adenosine, I'm sure we talked about this yesterday. We said adenosine has a very, very short half-life. So if you want to give it, you want to follow it with a flush. Most times, sometimes we say elevate the limb where you gave the medication. Sometimes we say go as close to the heart to give you adenosine because it breaks down easily. So you give it so that it can get to the point of action before it breaks down. And again, if you are a new nurse and you give adenosine, something is going to happen. When you give adenosine on the client, if you give him adenosine, it's going to go into the store. Again, the entrance control that the nurse what should the nurse do first? They will put option. I need you to remember that it is expected to have a transient asystole when you administer adenosine. So again, write that down. When you give adenosine, you want to follow it with a flush. And again, asystole is expected whenever you give adenosine. Okay, and again, from even my discussion, you will see that number 3 is a correct answer. Again, when we administer medication, we want to follow with a saline flush. So you want to administer it rapidly over 1 to 2 seconds and follow with a saline flush. Okay, at this point, I would like to say thank you, everybody, for joining. I can let you unmute yourself. If you have any question, you can ask. So let me allow you to unmute yourself. If you have any question, you can unmute yourself and ask your question. In the absence of any question, I'll quickly call it a day. Okay, sorry about that. My voice may be breaking. Actually, it's been a long day. Okay, so if you have any question, please, you can drop it in the chat or you can unmute yourself and ask your question. If not, we can call it a day. Okay.
Thank you.
Okay, you're welcome, Ma. Okay, so in the absence of any question, I'd like to say thank you, and everybody do have a good night rest. Thank you very much.